Good afternoon, folks. Welcome to Supporting the Workforce, Trauma-Informed Supervision for Supported Employment and Supported Housing Programs. It is great to have you here today. We are going to be hopefully increasing your knowledge, your competencies, skill sets in providing trauma-informed supervision. Um, Today's webinar is hosted by DBHR through the Washington State Healthcare Authority Act, uh, Healthcare Authority. This is an interactive training, and we encourage you to ask questions, participate throughout the session. Um, Please note that use of any automated note-taking bots, similar tools during Washington State FCS events or meetings requires prior approval. Unauthorized use of these tools is prohibited to ensure the privacy and confidentiality of attendees. Any recording that is created through AI is not recognized as an official recording of this training session, and we reserve the right to exit trainees from the training if unauthorized use of AI is taking place. Materials for today's session will be provided by me. I will upload into the chat today's PowerPoint material. In addition to our handouts, all of that will be downloadable through the chat feature. Additionally, a recording of today's session will be available on the HCA FCS YouTube channel, which is the Foundational Community Supports YouTube, approximately 2 weeks after today's session. I see more folks introducing themselves into the chat. Great to have you here. If you haven't already, go ahead and enter your name and where you're coming from and your role. It's always so exciting to see what diverse group we have for today. Thinking about today's session, we are talking about trauma. Trauma is pervasive, it's universal. We know that most people may have lived through one or more traumatic events in their lives, especially people that we serve, our staff, as well as, ourselves. Um, and so some identify more recently that we've experienced, collective trauma over the last couple of years, one with the COVID-19 pandemic, through socio-political unrest, things that are happening in terms of recent concerns with ICE activity, right? We see an increase in all of these um, potentially traumatizing, traumatic events. So be mindful of your wellness throughout today's session. If we're discussing something particularly challenging, a topic that might be eliciting emotions or some stress, please feel free to get up and take a break. During this break, do something that helps bring you back to a sense of calm and a feeling of connection or grounding to your body and to your senses. That might look like taking a tea or coffee break for some folks, a breathing exercise, or just going out for a bit of a walk. One of the tools that I use in kind of gauging my own internal barometer or meter of how I'm feeling and how content is hitting or how a conversation is hitting. I use this for myself. I use this for people that I work with and services. And I also use this with people that I've supervised. This is called the window of tolerance. And this is a tool to help assess the level of subjective anxiety, hypoarousal, distress. And it could be an important element for ourselves as supervisors, for tools to work with staff, or even individuals in service. Again, this was developed by a neurologist named Daniel Segal. It's called the window of tolerance. I'm going to put this worksheet into the chat in a moment. And this concept is used to describe an individual's optimal state of arousal or activation, where you can effectively manage um, your activities, engage in your environment, be social, regulate emotions. The window of tolerance is your 4, 5, 6 on this number line. That is where people feel a version of that their best selves, right? That they're focused, they can participate, they can be playful, at ease. It's a psychological comfort zone, right? That represents where we can mentally function well, right? Where we're able to focus cognitively. We are alert, engaged, capable of handling stressors without becoming overwhelmed or dissociating. And when a person is in that window of tolerance, they can effectively, again, regulate emotions, participate within conversations or work, maintain healthy social interactions. However, when we experience stressors, we can start to move outside our window of tolerance. When we move to the upper limit, 7, 8, 9, 10, this is a state of hyperarousal. In this state, we may experience intense emotions, panic, anxiety, hypervigilance. There's going to be somatic experiences in the body, maybe rapid heart rate, um, rapid breathing, sweating, feeling jittery, right? And then on the other hand, stress responses, traumatic responses, experiencing trauma and reacting to that trauma, we can move to this number line of 321, which is hypoarousal, where an individual really drops below that lower limit of their window of tolerance, resulting in emotional numbing, disassociation, shutting down, right? Feeling like you're not there. And so think about where you are right now. Take a good look at this number line and put in the chat, where are you coming in? I'm feeling right now probably at a 5. I'm going to put myself right at a 5. I'm alert. I'm focused. I feel like I can communicate effectively. I'm present. I'm waiting to interact with folks and engage in this session with you amazing practitioners. Where are you coming in at? See some 6s, some 4s, 5, 6, some 4s, 5-ish. Yeah. So I'm seeing around that window of tolerance, right? Maybe hitting a little lower or a little bit higher, but everyone's kind of hovering around that window of tolerance, so to speak. Use this tool as we move throughout the session. If you start to feel yourself shift, that's a sign to take the break, right? And again, you can use this tool with your teams as a supervisor. You can use this tool with people that you're providing services to. It's great for psychoeducation, for sharing with people this concept of window of tolerance. It's good for identifying triggers, what gets us out of our window. And it's also really good to identify our emotional regulation tools, right? Our body grounding tools to build capacity for wellness and getting back to our window. It helps us to note what gets us back to that sense of stability, stabilization, regulation, right? What are our tools and tricks to get back to our 4, 5, 6? So I found it to be a very versatile tool. And again, I'm going to put that in the chat for everyone. So you can download it and use it throughout your work week. Give me 1 second as I put that in the chat. Oh, it is not populating. It may take me a bit of a second, so maybe I could do that at the tail end. But I'm going to ask as we go through the training, just to be mindful, checking in with yourself and your body if you feel a shift, going hyper or hypo aroused. So our objectives for today's session, we are going to look at the definition of trauma and kind of clarify what are traumatic events. We're going to identify the impact of trauma on staff, direct service staff, and supported employment and supported housing. We're going to look at that piece of vicarious trauma, as well as burnout, things like compassion, satisfaction, and fatigue. We're going to look at the principles of trauma-informed supervision and hopefully apply some of that to our own work as a supervisor. So thinking about our topic, what is trauma? How do you define trauma? When you are in the work that you're doing, if waiting on granddaughter, that's amazing. Awesome. But thinking about trauma, how do you define it? You can put in the chat, what is trauma? personal, an adverse experience that can leave a lasting effect on the body or mind. Thank you, Madison. Yeah. An event or situation beyond a person is currently capable of handling. So it impacts them, and it impacts them in a way that they're challenged to navigate, to manage, to regulate, Kaylee. A stressor that exceeds a person's coping skills. Okay. Yeah, a person may have a significant challenge um, in terms of navigating the responses that happened. Past experiences that can hinder me now. Yeah, an event that psychologically, physiologically impacts an individual for indefinite amount of time or a series of events. Yes, Jacob. Great. You guys are spot on and you're kind of conceptualizing this definition, right? It's an experience that elicits a profound stress reaction due to someone said physical or psychological harm or threat of harm. When many people experience trauma during their lifetime, although many people who are exposed to trauma do not necessarily experience lingering symptoms. Individuals who experience repeated chronic or multiple traumas, like Jacob mentioned, multiple or series of events, are more likely to exhibit pronounced symptoms and experience negative consequences like substance use disorders, mental health conditions, even physical health problems. Trauma can significantly affect how individuals function in major life areas, as well as respond to treatment. This quote by Bessel van der Kolk really resonates with me. And let me know your thoughts in the chat. But trauma comes back as a reaction, not as a memory. And it really highlights the essential aspect of trauma's impact on an individual. Trauma or trauma experiences can become ingrained in the nervous system, right? Someone said in the chat that inability to cope, right? Because our nervous system is outside its window of tolerance. And this can lead to profound and often automatic reactions, triggered by reminders of the trauma rather than conscious memories. When individuals experience trauma, their brains and bodies can be wired to respond to those potential threats, even long after the traumatic event has passed. Someone noted that as well. For an indefinite amount of time, I think it was Jacob, right? An indefinite amount of time. And these reactions can manifest as that hyperarousal that we saw in Daniel Segal's window of tolerance, or hypoarousal when faced with situations or triggers that are reminiscent of the trauma. And these reactions are often unconscious and can be challenging for an individual to control, to manage, to comprehend without support, and for staff that are helping them to navigate those experiences, right? So thinking about, right, these reactions, what are they? What are these reactions? One, it starts with emotional reactions. Put it in the chat, some emotional reactions that can happen as a result of experiencing a potentially traumatic event. Put it in the chat. What are some emotional reactions that you think might happen? Absolutely, for this experience, you can't assume we're having brain process trauma. Yeah, outbursts, anger outbursts. Yeah, it could certainly bubble up and present as anger. Anger can be a protective emotion in terms of when people experience a traumatic event, right? Denial, sadness, shock, avoidance or hide, anger, extreme sadness, shut down. Yes, Kaylee, right? That sense of hypoaroused and now I'm feeling numb, right? There are a whole wide array of emotional responses. When we think about the people that we're serving, right? These can come across, but also the staff that we're supervising, right? Thinking about that lens of a supervisor, when people are experiencing these emotional reactions, that can significantly impact how they are able to be present in their work, how they feel in terms of their overall wellness. Maybe it impacts their job satisfaction when we're having these emotional reactions, right? There's also physical reactions to the experience of trauma. And again, I want to highlight this statement here, normal responses to abnormal events. We don't want to pathologize our body and our body's responses to these abnormal events, right? When we're hearing about trauma in a session with a person, when we're meeting with staff as a supervisor and they're sharing about their physical reactions, their emotional reactions to the exposure of trauma with the people that they're working with, these are normal responses to abnormal events. What do we think are some physical reactions? What would you think? You could put in the chat, you could unmute. Disassociation, anhedonia, right? That loss of joy. Jelly, yes, the body tenses. There can be that tension, that um, heart racing. Yeah, where we're holding our, even unbeknownst to us, maybe our shoulders are way up to our ears, right? We're holding those muscles tight. Jacob, tight throat, chest, armoring. Absolutely. We're keeping that body tight and that almost like in that flight mode, right? Where we're feeling that hyperarousal and getting ready to fight or flee. And so we can see, a whole bunch of physical responses. Think about how these responses, again, might interrupt someone's wellness and work, right? If we're supporting staff who are having these normal responses to the exposure of trauma and traumatic events, right? Think about the staff person that may be experiencing um, absenteeism, right? Maybe they're having a lot of sleepless nights because of some of the trauma that they have been exposed to in working with people and having that insomnia, and that might impact how they can show up. We might get body aches and pains, especially when we're holding, as Jacob and Shelley noted, that body so tight that can result in pain, right? Soreness. Shelley, illness, yes, yes. We see in literature that when we are constantly in that hyper-aroused state, when we're flooding our body with cortisol, norepinephrine, um, what we end up potentially impacting is our immune system. We wear that immune system down because it's causing inflammation in the body and it's, just impacting us systemically. Great point, Shelley. People mention, that fast pulse, that rapid heart rate, or just being easily startled. Cognitive reactions. This was an aha moment for me, learning that there are cognitive reactions to the experience of trauma. Why? Because we may be experiencing hyperarousal and it may be difficult to focus. When that center of our brain, our amygdala, is going off, that's the alarm portion of our brain that signals danger, danger, danger. When it's going off, we are getting less engagement in this portion of our brain here. This is our prefrontal cortex. And when that amygdala is going and alarming and telling us, right, a trauma, we're having traumatic stress responses, we are seeing a trigger, right? We are feeling that threat or danger. We cannot focus, think clearly, right? Um, our our more reptilian brain, our brain stem, and our lower brain is more activated. And so we see this in support education showing up frequently where people, students with trauma history have difficulty focusing. Think about your staff that you're supervising. If they're having cognitive reactions to the exposure to trauma and traumatic events or people with trauma in services, that's going to impact them as well cognitively, potentially. Right? Seeing some of these responses. Disassociation and withdrawal. Yes, that's that hypoarousal state, Shelley. Great point. Right? When we're hypoaroused, we are also cognitively foggy. Then we see these interpersonal reactions. And this is considerable, right? Where people may start to experience a sense of distrust, withdrawal, conflict, issues with school, irritability, right? How do you think that would interrupt or impact a staff person that you're supervising? Or if you're a staff person yourself, right? How would these interpersonal reactions to exposure to trauma impact work and wellness at work? What would that look like? You could put in the chat, you could unmute, but how would you envision these sets of reactions kind of impacting a staff person in supported employment or supported housing? Jacob, yeah, in every manner. Hard to focus on the people that we're providing service to. Conflict. right, Sean? Increased conflict. Brittany, that productivity, it may go down. Communication may not be as effective. It may interrupt our working alliance. Avoidance, Rachel. Yes. Yes. We're not experiencing safety, trustworthiness, connection. We're feeling, yes, Brittany, that diminished rapport building, that diminished working alliance. Working alliance is the opposite of the therapeutic alliance, but it's parallel, right? Our therapeutic alliance is with the people that we serve. Our working alliance is with our team. And so these interpersonal reactions will certainly diminish that rapport, like Brittany is saying. Paranoia, hypervigilance. Yeah, it's going to show up in a multitude of ways. Um, and I want to reiterate again that these are normal reactions, normal responses to abnormal events. And so if you are a direct service staff, keep them in mind, right? You're going to get the PowerPoint, you'll have these for reference. You can do a scan, a screen. Where am I at in my window of tolerance? Where am I at in seeing some of these reactions to traumatic stress, right? What's occurring? And as a supervisor, it's important that you provide that psychoeducation. That's a part of trauma-informed supervision, is letting folks know, right, that these responses are normal reactions to abnormal events. And it's how we manage them that we have to be mindful in moving forward, right? And why are we focusing on this piece of trauma? Well, when we look at the literature, the majority of individuals receiving public behavioral health services have experienced trauma. In fact, we see rates of anywhere contingent upon the study from 75 to 95%, up to 95% in some studies of people receiving public mental health services, your supported employment, your supported housing, your assertive community outreach, your ICMS, right? Or your what other practices do you have in Washington State that we have in New Jersey? Partial care programs or partial hospitalization programs, right? Upwards of 95% of folks receiving those services have experienced trauma. And many of them, I think Jacob made this point earlier, many of them have a scaffolding, one or more traumatic events that have happened, right? And that can be a multitude of events, right? It could be different categories of traumatic events. And so this deviates from the general population of people outside the public behavioral health service setting. We look at the general population, lifetime trauma, it's about 70%, right? 70% of people may experience a traumatic event. 95% of the people that we're working with, that is a huge difference, right? And that's why we want to be focused on this because it's not the exception that people are coming in with the experience of trauma. It is pretty much universal. We have to anticipate it, right, for the people that we serve. So, what constitutes a traumatic event? Oh, I think I see something in the chat. There are many categories of traumatic events that we want to have on our radar. And it's important to know for the people that we serve. And it's important to know for us as supervisors, for our staff, because the way people respond to different categories of trauma are a little different. And we want to kind of include that in our service conceptualization. So, natural trauma encompasses events such as natural disasters, hurricanes, earthquakes, floods that occur without human intervention. And these events can lead to significant psychological distress due to how they are very sudden or uncontrollable in nature, right? Conversely, human caused trauma arises from actions taken by individuals or groups, including war, terrorism, criminal activity. Think about, ICE activity that we have experienced across our country um, and how that's impacting people. Human caused trauma often involves a perceived intent to harm. right? When your trauma is at the hands of someone else versus a nature-based trauma, the person can look at, right, that perceived intent to harm, which can exacerbate feelings of fear, betrayal, and helplessness, or can exacerbate those interpersonal trauma responses, right? Interpersonal trauma occurs within relationships and involves betrayal, abuse, violence, oftentimes from someone the victim knows and trusts. This category includes domestic violence, child abuse, as well as sexual assault. And the relational aspect of interpersonal trauma often results in profound impact on the person, the survivor's ability to trust others, to maintain healthy relationships, right? Impacting their view of how they connect to the world and those around them, right? And that's really important to know if we're working with someone, right, in that trauma-informed supervisory approach, that we want to be mindful that interpersonal trauma can impact a person's worldview and their view of connection with others. Then we have developmental trauma, and that refers to exposure to traumatic events during critical periods of childhood development. This form of trauma can severely impact someone's emotional, psychological, and physical development. Developmental trauma often stems from neglect or abuse or living in chronically stressful environments. And the impact of developmental trauma can be very pervasive, influencing cognitive development, emotional regulation, even social skills. One way to look at some of those events occurring would be using the Adverse Childhood Events Survey. Adverse childhood events are specific types of developmental trauma that occur before the age of 18, and they're referred to as ACEs. ACEs include experiences such as physical and emotional abuse, neglect, household um, challenges like domestic violence, parental separation. And we know that there's Kaiser Permanente did a massive study to show that ACEs, right, are strongly correlated with a wide range of potentially negative health outcomes in adulthood, including mental health issues, chronic disease, reduced life expectancy. We see correlations to alcohol usage, COPD, chronic obstructive pulmonary disease, depression, um, drug use, ischemic heart disease, things that you wouldn't even consider connected to the experience of developmental trauma. So just by these studies alone, we can see the profound impact of trauma. Then we have individual versus group trauma. Individual trauma refers to events that impact a single person, like a personal assault, robbery, or a car accident. And the effects of individual trauma can deeply impact a person and lead to psychological and emotional responses, right? Also impacting that individual and potentially their worldview. Group trauma, on the other hand, affects a collective, right? A community, an entire population. Examples can include mass shootings, natural disasters, pandemics, um, certain communities, cultural communities. Um, trauma can really foster a shared sense of loss and may influence collective identity and social cohesion, right? People kind of come together and rally around this experience and try to support one another. Um, then there is racial trauma, also known as race-based traumatic stress, and that refers to psychological and emotional harm caused by the experiences of racism, discrimination, systemic oppression. And this type of trauma can be triggered by direct experiences like racial slurs, hate crimes, racial profiling, as well as indirect experiences such as witnessing racism, learning about racial injustice. Again, I'm called to think about the ICE raids in this country and the trauma that's happening there. The cumulative effect of these experiences can lead to chronic stress, anxiety, depression, mental health conditions. Racial trauma is often intergenerational, affecting not only those directly exposed to racism, but to subsequent generations, right, through transmission of stress and coping mechanisms. And addressing racial trauma requires both individual and systemic approaches, and is something to be mindful of as we continue our work in this session. And then there's generational trauma or intergenerational trauma. And that refers to the transmission of trauma from one generation to the next. This phenomenon can occur through various mechanisms. Um, Generational trauma is often observed in communities that have experienced significant historical trauma, such as indigenous populations, descendants of people that were enslaved, survivors of genocide, right? The effects of generational trauma can manifest in a wide range of ways, including increased vulnerability to mental health conditions, um, developing different coping strategies, altered stress responses, right? So that's what we may see in terms of people that we serve and some things that we may experience. When we think about the practitioner's lens of categories of trauma, what comes to mind is secondary traumatic stress. Traumatic stress or secondary trauma. And that's PTSD-like symptoms that occur after exposure to another person's traumatic events, right? If people are sharing with us, and it affects the nervous system, emotions, body reactions. This can occur suddenly, even after, one meeting with an individual, right? And this may result in intrusive images from the person's story, nightmares, hypervigilance, startle response, right? All of those stress responses that we discussed earlier. And then a little bit more insidious is vicarious trauma. And that's a change in the helper's inner world caused by repeated empathetic engagement with others' trauma, right? When we're continually working with people with traumatic experiences and we start to kind of shift our worldview, our beliefs about safety, trust, control, intimacy, identity, right? It's how we experience as staff, supervisors, the world outside of work. It changes over time, right? So the trauma that we are exposed to in vicarious trauma can reshape how we see humanity and how we see ourselves. That might look like the world feels dangerous now. People are difficult to trust, feeling cynicism, hopelessness, or permanently changed, questioning meaning or purpose. So thinking about that, right? What do you see in the work that you do? Anything come up for you? Anything come up for folks as we go over these categories of trauma? Do you see them in the work that you do? Are people served coming in with experiences of traumatic events? Or are you seeing staff come in with some of that secondary traumatic stress or vicarious trauma? You could unmute, you could put it in the chat. Yes, always, Samantha. Yeah. Yes, I had to take a few breaks. It's okay, Mika. Please check in with yourself, and take that break. Get back to your window of tolerance. Be gentle. We always talk about, grace, that empathy inward. And I want everyone to be practicing that today. I'm seeing it in the people we serve. It does infect employees. Yes, Shelley. Yeah, Sean. Yeah, it is very prevalent. In terms of our experiences, right? Before we dig into supervisory practices, what is our scale of exposure? Mental health work is one of the few professions where repeated contact with trauma is not just incidental, it's routine, right? Over time, providers are affected, not because we're unskilled, but because, um, that empathetic engagement requires being psychologically um, close, right? That psychological proximity to people experiencing trauma, to people experiencing traumatic stress. And research, consistently identifies three related occupational responses. Again, that traumatic stress response, vicarious trauma, and that burnout. And we know that across literature, across studies, um, 70% of respondents in the mental health workforce were identifying as experiencing chronic secondary traumatic stress during their careers. 70%, right? That's a pretty high rate. That is more than half of the workforce, right? It's almost three-quarters of the workforce that answered that response, um, is identifying, endorsing the experience of having secondary traumatic stress. We also see more broadly That vicarious trauma rates range anywhere from 21 to 74% among mental health providers, depending on the setting and the resources. And we're going to get into that. The setting and the resources matter. Your agency and your organization matter, right? Being trauma informed is not just an individual responsibility of the supervisor, it's an organization and program's responsibility. And there are things that they can do, you can do within that organization to support that. And then we see 18% of respondents reporting secondary traumatic stress responses at levels comparable to meet criteria for PTSD, right? And these effects are going to impact clinical judgment, therapeutic alliance and engagement, potentially service outcomes, but also personal wellness, right? Also personal wellness. It doesn't stay siloed, right? These experiences and this traumatic impact doesn't stay within the domain of work. It starts to slowly creep out to a person's other life domains, right? Living, where they live, who they live with, learning, their role in school, working, that's where it starts, and social, their connections with others, right? So we have to be very mindful that we are building our trauma-informed lens and trauma-informed supervision, yes, to support that person, that staff person in their world of work, but also to preserve wellness in their other life domains, right? That's how we lose people in our field. When this work becomes so overwhelming, when people are walking around with that vicarious trauma, with the secondary traumatic stress, and it starts to deteriorate their quality of life or those other life domains. You see some things coming into the chat. Seeing it in people that are served, and it does affect employees, of course. Yes, we are sitting there with our empathy and our reflective listening and making ourselves available to validate, to support and process. And so there's a toll to, again, that psychological proximity in bearing witness and supporting someone who's experienced trauma. Systems they've utilized that have historically pathologized or paternalized. Yes, Jacob. We see a lot of over pathologizing, right? Trauma responses are normative responses to an abnormal event. And so I think there's something, really validating in hearing that, right? That um, what's abnormal is the event, right? What happened was wrong and it shouldn't have happened. And how our body's responding, it's finding whatever way it can to live through and survive and or thrive in what we experienced, observed, or bearing witness to, supporting someone through as a staff person, right? What can be difficult about secondary and vicarious trauma and social services? Often people, staff are aware that is what they're experiencing, even when they know what it is. Yes, Rachel. And so we're gonna make that, right, that vague gray area more concrete today with using an assessment in just a moment. You're going to help people to really score, if you will, their areas of compassion, satisfaction, burnout, as well as secondary traumatic stress and vicarious trauma. And so we think about our exposure to these things, right? We want to know, well, what can be done, right? If this is a work hazard, what can be done? And so we see in this first piece of how do we solve it? What do we do? There are organizational factors, starting from a leadership and organizational perspective, that can hopefully, if we are mindful to address these concerns, reduce the risk of vicarious trauma, reduce the risk of burnout and traumatic stress, right? And that starts with this was a study done with that showed six organizational factors. First was caseload or service load, but not just how many people someone was serving. Risk increased when staff had repeated exposure to highly distressing experiences, interpersonal violence, especially when they felt overwhelmed. So exposure is defined by meeting and not numbers. The second factor was the strongest relational protection, supervision quality. Wow. That means for you supervisors sitting in here right now, that that is a protective factor. And that's something we have locus of control over. Frequency of supervision alone did not reduce the impact of trauma. Supervision that was, for all intents and purposes, trauma informed, where there was validation, reflection, collaborative support. When that supervisor was not just doing administrative supervision, but doing restorative supervision. And we're going to talk about that in a moment. Peer support was the third factor or variable. Talking with coworkers like we're doing today, connecting with one another, helping us to process or gain perspective. When conversations reinforce frustration or negativity, though, it increased stress rather than reduced it. Then there's this piece of organizational culture, workplaces where reactions were normalized, like Jacob was saying, right? We don't over pathologize, we normalize, right? Yes, this is hard work. Yes, we're exposed to these events. Yes, it may show up this way. How do we navigate that? How do we support one another? How do we discuss it openly, give it a name, and find ways to regulate, to co-regulate with one another, right? That was shown to reduce those trauma responses. In workplaces where distress was minimized or stigmatized, we saw trauma responses increase. Fifth was training. Information did not alone did not help, right? Training reduced impact only when it built awareness and support to reflect and to process. And then support matters. Structural support was important. Leadership accountability, um, folks having autonomy, balanced roles to reduce trauma impact while navigating, paper workload, productivity pressures, lack of resources, right? And that all of those things kind of increased those vicarious trauma responses. So finding support and structure and balance was essential. And so one way to start, as we just saw in our comments, right, where Rachel said, people may not know what's going on. They may feel it, they may be experiencing it, they could be living it, but how do they know? How do they know that their wellness is being diminished as a staff person, as a supervisor, because of their exposure to trauma? Are they experiencing burnout, vicarious trauma? One of the best tools that I have used and I'm going to actually have you guys go out into breakout group rooms and complete this, is the professional quality of life assessment. This is free. There's no cost to it, zero cost to you. I'm putting the link in the chat. It is called the ProQual, Professional Quality of Life. It was developed to measure the negative and positive effects of working with those who've experienced trauma. And there are subscales that include the compassion satisfaction, burnout, compassion fatigue, and I believe vicarious trauma was added. And it's a valid measure for these particular constructs. It will take approximately 7 minutes to complete. It's not an evaluation. It's not something that you have to share with anyone, and it's not a mental health screening. It's a self-monitoring tool that you as a direct service person or a supervisor can help people to check, help staff to notice patterns in how they're feeling, how their work is going. Where are they coming in at these different areas, right? So as I put you in a breakout group room, you'll click on that link and you'll go through the 30 questions on a Likert scale. You'll answer based on your experiences over the past 30 days. After you complete it, you'll be asked to give an email and they'll give you your results emailed, right? So if you want to use a personal email rather than your work email, by all means, go ahead. And as you sit with your group members, you don't have to share your scores, right? I'm not going to ask you to over disclose, but share with your group members. Did anything surprise you? Did the results match how you've been feeling? Right? Is there an area that you want to pay attention to over the next month? And I'll put those questions in the chat. right? Did anything surprise you? Did the results match how you're feeling? Is there an area that you want to pay attention to? Let's see if this will paste into the chat. Any questions before I put you in your breakout group rooms? Okay. As we head in, just be prepared to check in about how that went when we get back. This is your first free tool for addressing trauma-informed supervision, right? How to assess it. If you need help getting into your room, I'm here to assist. Also, I'll monitor to make sure that everyone has a partner.
Hi, Amy. I'm logged in twice, once on my computer and once on my phone. Can you get both of my accounts into the same breakout room?
Oh, yes, I can try.
Right now I'm in 1 and 7.
Okay, I will put you in 7.
Thank you.
See, does everyone have a partner? Does anyone need help getting into their room? I'm going to resume that recording, but thank you so much for sharing. This tool, again, is completely free. You can use it within your supervision, or you can use it yourself as a direct service staff member to just check in. And again, like we did with the window of tolerance, we're just getting a measure. We're gauging um, where we're at, giving ourselves um, a data point to look at and say, hey, this is not where I want it to be. Or, hey, I'm doing really well. I'm doing better than when I was previously. I have made improvements, right? It's always good to get that data. Um, and that is certainly a part of our trauma-informed supervision, right? It's a supervisory approach that applies the principles of trauma-informed care to the supervisory relationship itself, right? The supervisor intentionally structures interactions so that staff experience safety, trust, collaboration, right? Choice, um, and hopefully, right, the same conditions that we are providing when we're working with people in service. And that's a parallel process, right? Staff learn trauma-informed practice um, in their trainings and in their work, but they also learn it in supervision and how we navigate supervision, right? We can model that trauma-informed practice in our supervision. And so really, when we talk about trauma-informed supervision, it has two components or two objectives, right? One, to help people provide trauma-informed care, right? um, Helping staff as supervisors to understand how trauma affects behavior, wellness, communication, engagement, right? That's the psychoeducation piece of trauma-informed care. And second, it's helping the workforce to manage the emotional impact of the work that we do, right? So trauma-informed supervision is kind of two-pronged. We're helping staff to be trauma-informed in their work, and we're addressing the emotional toll through our practices of supervision that staff may experience, right? And so we are using the supervisor relationship itself to teach trauma-informed practices while supporting staff functioning without crossing over into counseling or therapy. We're not their mental health provider, right? Um, and so that may look like, right, in meetings, creating psychological safety, supporting reflective thinking, maintaining accountability and self-care in that work culture, sustaining staff capacity over time. And so I pulled from this article that looks specifically, right, at what are the principles of trauma-informed supervision. The first four components um, look at mental health providers and supervisors, and they acknowledge, right, that we have to establish conditions under which staff feel that safety and can, again, think clearly, make intentional practices, help to manage emotional activation that supports, reasoning during challenging work. So the first step of trauma-informed supervision, after we inform people of that psychoeducation, after we use that window of tolerance, after we use our pro-qual, is embodying this first principle of acknowledging and witnessing. Supervision begins by recognizing the impact of the work, right? The emotional toll, the mental toll, right? And this is not counseling the supervisee. It's acknowledging the exposure to distressing situations, trauma, right? Um, and how that influences staff wellness, attention, interpretation, decision making, all of those potential abnormal event responses that we may see that we started with earlier, right? Brief validation, validation in general reduces defensiveness, helps the staff to shift from reacting to analyzing. Without this step, I think the supervision often feels like it's moving on too quickly, like we're not giving time and attention to that process and what's happening. Um, right. And the purpose is really to restore that wellness for the staff and that validation and witnessing, so that problem solving can begin, right? Then we see encourage self-awareness and reflection. And when we think about that, we want to help the staff in identifying what they noticed, how they interpreted things, right? How what they noticed, what they interpreted may have shaped their response in an interaction. Kind of building metacognition, building that reflective practice, right? The ability to monitor and check in on one's thinking, which is central to trauma-informed practices, right? The goal is not emotional processing for the sake of its own, but to help provide clarity, intentionality, help the person to understand any of those trauma responses, those stress responses that are occurring, and how to support that person. Then we see neutralize the environment. And this goes back to preventing re-traumatization. Supervision itself can increase or decrease that threat response, threat response, when interactions feel like they are um, rushed, unclear, directive or corrective. When people use certain tones, certain verbiage, certain, language, this can elicit, right, some of those strong responses when people are experiencing vicarious trauma or traumatic stress. So we want to be mindful of that, right? Neutralizing that environment, being clear in our communication, using calm tone, finding ways to prevent the triggering of some of those trauma responses. And then balance and flexibility, or clear expectations, right? Trauma-informed supervision combines that consistency with responsiveness, right? Clear expectations provides predictability, while we offer, flexibility, allowing adaptations for certain circumstances. Both are really important, right? Predictability supports development of trust, flexibility supports engagement, as well as connection. Um, so thinking about these specific principles of trauma-informed supervision, what comes up for folks? Anything at all? Are you doing some of these already? I would assume many folks already are, and not necessarily categorizing it as trauma-informed supervision principles or framework. Anything coming up? Again, we're looking at ways to create safety within the supervisory relationship, supporting trust, trustworthiness, increasing autonomy and choice. Very much like a parallel process to trauma-informed care in the people that we are providing services to. We're mirroring it now in the supervisory sessions. And that can be individual sessions, that can be team meetings, right? We want these different principles to show up in any capacity, right? To be available, allow space for staff to process if they ask for it. Yeah, I think that can be very important. People cite having that opportunity to debrief Rachel as a really good support. And that can be with the supervisor, or as we noted earlier, right, in the organizational component of preventing vicarious trauma, it can be even with uh, colleagues, other staff. Okay, thinking about the other four components of trauma-informed supervision. Um, we looked at, right, this piece of model and promote wellness, that supervisors demonstrate regulation through how supervision ultimately is conducted. And that can look like tone, that can look like, again, language. It can be pacing. It can be how we denote urgency or calmness, prioritization, even boundaries. Um, I know some supervisors may pride themselves on being overly accessible, on never taking vacation, never taking a sick day. What do we think about that? Is that modeling wellness? Is that modeling and promoting wellness? When we come from this framework that it's exemplary, ideal, um, to not take our vacation time, sick days, right? That's sending a message, and people are picking up on it. No, absolutely not. Everyone needs time off. Yes, everyone needs time off. Yes, Rachel, post-traumatic resilience and post-traumatic growth are a considerable piece of this experience. And we do have more information. Yeah, more information on post-traumatic growth. And that's where we as supervisors are going to support meaning making, right? Looking at the impact of the work, looking at capacity, opportunity, and hope. Those things can absolutely support post-traumatic growth, where a person is processing what transpired and they are now incorporating that experience and finding resilience, finding strength, right? Maybe it's reaffirming how the response was, right? That staff came together and supported a person through a crisis. And that can reaffirm person's views of connection, community, helping, right? Um, of humanity, right? So that's a big part of how we as supervisors can look at that meaning making and potentially find those opportunities for post-traumatic growth. And there was another question in the chat. More information with regulation. Yes, I do. It's coming up in just a moment in our next slide. But we're going to talk about restorative supervision and somatic practices for co-regulation. Love that. And so the other component, right, after modeling and promoting wellness is addressing the impact of the work, naming it. Someone said earlier, people may have challenges identifying. They know that vicarious trauma exists. They know that secondary traumatic stress exists, that burnout exists, but they might not name it. And so in this piece of trauma-informed supervision, we're having very open conversations. We're checking in with the person. We can use our profile to talk about, the impact of the work, what repeated exposure of trauma can, influence a person's wellness, work functioning, wellness outside of work, expectations, interpretations, right? And kind of naming all of these effects can allow staff the verbiage, the time and reflection to identify what's going on, to find collaboratively in supervision solutions. Maybe that looks like um, switching up again the composition of the workload, right? Of the caseload, where they're not working with as many people with significant trauma histories. Maybe it's putting breaks into their day, right? Having a little bit of a buffer. I know one of my strategies as a supervisor in addressing the impact of the work was doing a check-in at the end of the day. How did it go? A lot of my staff were mobile in the community. And I'm sure that's the same for you folks, right? We're out, we're driving. One appointment to the next, we are moving across town, we're moving across the county, we're moving across the state. We might not see another coworker that day. We might not see another coworker for 2, 3, 4, 5 days, depending on what our workflow is like. And so ending the workday with a call, a check-in. How did it go? What felt heavy? Right? What how are you starting tomorrow off? In what ways can we look at wellness strategies? Right? Are you taking a break and getting your lunch in before you see this next person that has this extensive trauma history? Right? We want to address the impact of the work and build supports around it. Also, this piece of providing culturally responsive support, right? Supervision can shape how staff interpret behavior across different roles, identity, cultural context. So, creating space to examine, um, this cultural lens, looking at assumptions, bias, preventing misinterpretation, supporting more accurate service strategies, engagement strategies, wellness strategies. And the aim here is to improve understanding, right? Is to come from that place of cultural humility and being curious and open, and looking to expand perspective to improve, whether it's service conceptualization, whether it's professional judgment, whatever it may be. We're looking at being culturally responsive in our support and our interaction. And then looking at capacity, opportunity, and hope, right? Supervision that consistently identifies effective actions, incremental progress, strengthens staff expectations of change, strengthens staff in terms of their experience of that post-traumatic growth, right? Demonstrating, highlighting resilience, highlighting strength, highlighting um, the hope and optimism, um, right? And that does not replace problem solving or ignoring problems. It's balancing perspective. So we can support staff in really seeing a full picture and engaging with our ongoing work and what we do and the challenges that we may experience. Um, so I'm going to put into the chat a handout that has all of these principles listed within the trauma-informed framework. Let's see. Oh, it's saying that I can't put it into the chat. Why not? I think I have to close out the document. So hold on one second and I'll put that worksheet into the chat. But someone was saying, how do we co-regulate? And that really comes through potentially our piece of restorative supervision. So we started out this supervisory framework many sessions ago, talking about the functions of supervision. Um, Supervision can focus on administrative supervision or what we call normative supervision. And that's all about quality assurance, compliance. Is your paperwork done? Did you, follow the company car protocol, and do the monthly assessment of the car, right? Um, Normative supervision is helpful. It's helpful to make sure policies and procedures are being followed, but normative supervision does not address vicarious trauma and secondary traumatic stress. It does not address staff wellness. Um, the formative supervision is the teaching component. It's where we help people to learn counseling skills, communication skills, supported housing approaches, supported employment interventions, job development, job coaching, right? Speaking to tenants, um, ADLs, activities of daily living, all of those things, the skills teaching that we want staff to do. We can role play, we can do trainings, webinars, um, in that formative supervision. We're forming their skills, but that doesn't address the wellness of staff. In that supervision, we're not checking in on staff wellness. We don't talk about secondary traumatic stress or vicarious trauma or burnout. That happens in the third function of supervision, and that's restorative supervision. And that's where your trauma informed approaches really shine. Everything else should be trauma informed. Every lens that you use for supervision, whether it's normative, formative, restorative, should be trauma informed. But restorative supervision, this is where it's really going to come through because we are focused on staff wellness, right? It's being about present to the person behind the professional, especially in our high stress environments like supported employment and supported housing. And again, it's not therapy, but it is supportive. It invites discussion of, staff wellness, celebrating resilience, that post-traumatic growth, supporting just overall supervisees' well-being. And when we provide restorative supervision in that trauma informed lens, it reduces burnout, it improves retention, right? Um, and so some things that we can do in restorative supervision, some skills to use would be one, the profile, helping people to give a name and a number to what they're experiencing, to systematically check in to see where they're at with their numbers. Are things getting better? Are they improving? Are they getting worse? Right? We can go over those organizational approaches in mitigating trauma responses and restorative supervision. How's the caseload? Is it too um, demanding in terms of the type of people or the observations, the things that you're kind of getting exposed to and the folks that you're working with? Do we need to think about, as we're assigning new folks, different ways, strategies to assign new folks to reduce the exposure there? But it's also that co-regulation, and that can look like modeling. Right, modeling calm voice, modeling less or like not such a high emotional response or a sense of like pressing urgency, but calm and paced tone, right? That's going to support co-regulation, as well as these somatic techniques for co-regulation. Somatic skills for wellness are valuable tools in the work that we do. They can be used with people that we serve and with our staff. Bilateral stimulation involves rhythmic, repetitive movement that engages both sides of the body, therefore both sides of the brain, and that can include eye movement or it can include tapping. It activates the brain's natural ability to process and integrate traumatic memories, traumatic stress. through mechanisms associated with EMDR, which is eye movement desensitization and reprocessing therapy. And there's a lot of evidence behind this in terms of using bilateral stimulation. It's been studied in EMDR research and in treating people with trauma-related disorders, including PTSD, and it's been shown to be effective. It has, a good rate of efficacy in reducing those trauma responses and improving well-being. So an example of this bilateral stimulation is going to be one technique, the butterfly hug. You lock your thumbs, right? And you have your butterfly. You put your butterfly to your chest and you gently tap, right? This is very obvious. If you're doing this with your team, with a staff person to get that bilateral stimulation, at that slow rhythmic tap, people are going to see that you're doing it. Um, and it's something you could do in team meeting, right? Have everyone to kind of try that and to see how that sits with that co-regulation. To be more discreet, you can have the person just take their hands and tap on their legs, right? And again, when we are using these techniques, yes, we're using it to see how it sits in our window of tolerance, if it brings us back to a sense of calm and regulation. But we also are using it to see, can I teach this to somebody else? Maybe a job seeker gets really nervous before an interview and they can use some knee tapping bilateral stimulation. Or maybe a tenant gets really anxious um, when they are going to the laundromat or they have to go grocery shopping and maybe they can use a butterfly hug. Breathing exercises, that diaphragmatic breathing, box breathing is really good. And the key with relaxation, the breathing exercises, um, is to increase the exhalation. For years and years and years, I would do these breathing exercises and I would like kind of induce a panic attack because I was inhaling. I was doing a very long inhalation. And what we see in trauma research and what we see in research on our autonomic nervous system is that when we inhale and extend it, making that a long inhale, we're activating our autonomic nervous system and it's making us more anxious. So if you ever tried deep breathing and you're inhaling a lot and you're like, I'm getting more nervous, that's kind of how the body works. And that may be why it didn't work for you. We want to actually extend our exhalation. So it's a normal inhale in to the nose, and you want to breathe out of your exhalation like you're actually using a straw, right? My trauma instructor, professor taught me this technique, and she actually brought straws in where we all took a little cocktail straw, normal inhale through the nose, and a long extended exhale. And I wear a Fitbit. You could see that heart rate dropping. So breathing exercises can be great. Find one that works for you. It took me a while. It took me a very long time, but I found it. And there are some resources, I think, listed for some of these breathing exercises that you can do as a team, right? You had a rough outreach, do that bilateral stimulation or that breathing exercise. One of my favorite guided meditations is the Safe Place guided meditation, where we help people to create a mental safe space using their imagination. And this safe place helps them to feel secure and calm during challenging moments. Um, Evidence on the Safe Place guided meditation, I don't have much. It's kind of limited, but guided meditations have been studied and shown to be effective in reducing hyperarousal. So we might extend that to the Safe Place guided meditation. I do have one linked that is very relaxing. It's about 5 minutes and it helps you to think about a place that you feel completely safe, a place that helps you to feel a sense of peace and calm and wellness, joy. And that safe place could be a place that you've been to. It can be a place that you want to be visiting. Maybe for you, a safe place is Hogwarts because you are a huge Harry Potter fan. Or maybe it's the beach that you've been to. For me, my safe place is my grandmother's backyard, right? So that is a good exercise that can be discreet to do where you go through that guided meditation. And then grounding exercises is another good technique for staff wellness, for restorative practice, and using our five senses to anchor oneself into the present moment, providing sense of safety, stability, especially if we're having some of that traumatic stress or sense of overwhelm. And grounding techniques are widely used in trauma-informed care and trauma therapy, and there's a bunch of research that supports their efficacy because really what we're doing is helping people to be in that present moment, really feel grounded in their body, in their senses, and that takes away that sensation of being in that hypo-aroused state, that numb, dissociative feeling. And so these are some simple free practices that you can use. And I have some YouTube videos linked in those resources. All right. So thoughts for today. Thoughts for today. I know we talked a lot about trauma, the experience of trauma for people served, as well as staff, what we can do as supervisors. I want to open it up for any questions, comments, or even what you're taking away from today. And I will pause or end the video so that we have some space in debriefing.